Hello, everybody. Welcome to A Manic Odyssey and this continuing awesome conversation about DBT and modalities of therapy. Today, I have not one, but two incredible guests at the exact same time. Dr. Suzanne Wallach and Daniele Lewin, LMFT of SoCal DBT. Hello, everybody.
Morning.
Good
Hi,
morning.
thanks for
Good
having
morning.
us.
Of course. Thanks for doing this. And it's going to be so fun having two at the same time because you get to, play off of each other, and one person's going to be like, I don't know, I would say this, and the other person would be like, I don't know, I would say this. So we'll just start with the basics. Let the audience know, who are you, and what does your practice look like, and how did you get into DBT? Whoever would like to go first.
Oh, goodness. Do you want me to go first?
Sure.
Okay, my name is Dr. Suzanne Wallach, and I am a licensed marriage and family therapist. I work in Los Angeles, California. I specialize in borderline personality disorder and complex trauma and a few other things, substance abuse, eating disorders. I feel like high conflict families. I work with children aged 12 and then across the lifespan. Really enjoy working with parents and families and young adults and teens. But that said, I also enjoy working with adults too. Um, what was the other question? How did I get into DBT?
Yeah, well, maybe we should start. Wait, we'll pause there. This is who you
Yeah,
are. Then we'll go, Danielle, who are
yeah,
you? And then we'll go back to the how did you get it? Because I feel like that's going to be a we're gonna go deep on that one.
yeah, that's a loaded question.
That is a big question.
Yeah.
I'm Danielle Lewin, licensed marriage and family therapist, and I'm the clinical director at SoCal DBT. I also specialize in borderline personality disorder in adults, and then also disruptive mood dysregulation disorder in children. So I work with kids starting as young as 6, and then also through the lifespan. And I also do some work with parents and families as well.
Amazing. Okay, now, how did you guys get into DBT? What led you to that modality of therapy? Was it undergrad? Was there a life moment? Was it an experience? Or were you just like, you came out of the womb and you were like, dialectics?
I took a long and twisty road into DBT. So I initially wanted to work with eating disorders when I was in grad school, and I did that. And then that was really not the place for me. Even though I still do work with eating disorders, acute eating disorders was not really where I found my specialty to be. And from there, I started working in substance abuse. And I really loved working with substance abuse. And what I found working in substance abuse is that substance abuse patients, there was often a comorbidity with personality disorders.
Mm.
And so after I graduated and I was working at a community mental health center, I went to work in treatment centers when I was completing my licensure hours. And through there, I was offered a job at a psychiatric practice at Cedars-Sinai, where there was a group of psychiatrists that specialized in treating substance issues. And I ended up just having a caseload where I had a lot of clients that were diagnosed with borderline personality disorder. And at the time, I was not trained in DBT. And I did really, really well with these clients, and I really liked working with them. But I found that being psychodynamically trained, which was what I was very passionate about at the time, I was very into Freudian therapy, and I wanted to become an analyst and have a couch and see clients 5 days a week and make interpretations and do all kinds of fancy analytic stuff. I found that I would get to a certain place with these clients and we would figure out why they were the way they were. And then we would get very stuck. And my clients would get very frustrated because I would we'd get to a place, and in psychoanalytic theory, I wouldn't be able to tell them what to do.
Mm.
And so it would be like, sort of be like, well, it must be very frustrating for you that I can't give you direction. And that must feel very frustrating for you. And let's talk about how frustrated you are. And my clients would leave. And
Yeah.
so I, at that point, sort of was like, well, this doesn't feel very fulfilling for me as a therapist. And so I decided to get trained in DBT. And that was when I went. It was 2014. And it was the first year that behavioral tech, Marshall Linehan's training institute, offered training for private practice therapists that were not already on DBT teams. If you were in a private practice by yourself, you could fly to Seattle and they would put you on a team with other private practice therapists across the country. And it was a 2-year training.
Whoa.
And they would train you in Seattle, and then you would be on like a virtual team and you could learn how to do DBT in private practice. And so that was what I did. And it just went from there. And
Wow.
it changed my life completely in all of the best ways.
Wow. Wow.
Yeah.
I have so many questions. You said so many things that made my brain go.
Yeah.
I especially connected with this is annoying that you can't tell me at least what to do a little bit.
No, I could not.
You could not. Okay, cool. Well, Danielle, how about you? How did you wind up on this road?
Yeah. So some overlap with Suzanne just in terms of getting trained in other modalities and then feeling like I was hitting a stuck point with clients. So when I was in graduate school, I started earning my licensure hours at a training site that was also community mental health, working mostly with children, adolescents, and families. And there was a lot of trauma and a lot of self-harm. And the supervisors that I had at the time were wonderful. And they were really psychodynamic and humanistic. And I felt like I was being faced with these pretty acute symptoms that I didn't know how to approach behaviorally, right? Like I helped the clients gain insight, and I had a lot of interpretations and thoughts about how they got to where they were, but I felt pretty helpless in the moment trying to coach young people through really big, painful emotions.
Yeah.
And so I felt like I needed to get trained in some sort of behavioral modality so that I had something concrete, and hopefully could feel a little less helpless in the room with my clients and empower them, right, to have strategies to cope with their circumstances that were so difficult. So I finished graduate school at USC and then was looking for a placement that would allow me to get some training in a behavioral modality. And DBT, from the little bit that I knew about it at the time, really resonated with me. So I found Suzanne's practice. And I would say from the moment that I walked into her office, I said, I need to learn from you. Personality-wise, we really gelled, and I just felt like
It was love at first sight.
Yes, it really was.
You know, from the outfit she had on to wisdom, the knowledge
Yes.
that she had. I just knew it was going to be my home for a long time. And the more that I learned about DBT, the more I realized it didn't just resonate for me as a clinician and give me those tools I was looking for, but it really resonated for me in terms of this like philosophy and worldview. That's something that we talk about a lot within our practice, is that to be an effective DBT clinician, you really have to sort of be immersed in this like DBT culture and approach to life, because it really is sort of a framework or a worldview. Like Suzanne, adopting that has really transformed my life personally as well.
Wow. Wow. We have so much to dive into, you guys. That was so great. What came to mind, Danielle, as you were explaining your love at first sight story is like, when you find the person you want to do DBT with for the rest of your life, you want the rest of your life to start right now. My first thing I wanted to touch on real quick was the specialization with BPD and the overlap with the 12 steps groups, which I know you didn't say that specifically, but you talked about substance abuse, and I'm sure there was a lot of running into people who are a part of those communities. I had a therapist at one point who suggested that I was a part of the 12 steps program and suggested I be a part of it as quickly as possible. Ironically, what was great is that I found an amazing community of likewise of guys who were all struggling basically identically with the same urges, the same compulsive nature, the same destructive behaviors. The solution, of course, to them and to me at the time was, oh, well, we got to internalize the 12 steps. And what I find hilariously ironic is that I made some great friends who would give amazing book suggestions. I'm a big book guy, so you got book suggestions, send them my way. And one of those books was Unbroken Brain. Have either of you read that book?
I haven't.
It's written by a woman who went through the AA program specifically, and she had a mixed bag, but mostly a negative experience, which is not normally shared publicly because most people who have positive experiences are very loud.
Mhm.
And she touches on the fact that any given room, there would be 50 to 60% people with personality disorders. And that would put people who didn't have personality disorders at a disadvantage for things like manipulation or abuse of power, not necessarily because the group itself fosters these individuals. It's just that what we're talking about, when you have these types of behaviors, you're drawn to other people who kind of will either validate your own behaviors or make sense of it. For me, it was like, oh, this makes sense. Like I was looking for an answer and they were like, well, this is the reasons why. And I was like, okay, well, I didn't have DBT at the time. So I was like, oh, this makes sense. So, in your experience working with people who have personality disorders and also struggle with substance abuse, uh, why is it that some clinicians are still pushing people towards 12 steps instead of something like DBT outside of the cost idea of it? Because I know most therapists will push for 12 steps because it's free. However, in my limited experience, it seems like you would save a lot of people a lot of time and heartache if you said, do whatever you can in your power to actually go do this program, which will be more long-term beneficial. Does that question make sense?
It does. I mean, I think that there's a lot of different answers to,
Yeah.
or not answers. I think there's a lot of different ways that you could sort of like try to answer that question. I think, first of all, there's a lot of therapists that are in the 12-step program. And
Right.
so they think that, and first of all, nothing against the 12 steps. My husband is 32 years sober and also kind of a lapsed AA, or he now does more of like a Buddhist approach to recovery,
Mhm.
refuge recovery, and sort of like, has his own issues with AA now, 32 years into sobriety,
Yeah.
and was very hardcore AA for a long time and is 32 years sober. And but like, and I'm very familiar with the 12 steps and things like that. But I think there's a lot of therapists in recovery on their own who
Yeah.
are very hardcore AA. And so I think that's the only way. I think there's a lot of therapists that are uneducated and think that 12 steps is the only way. And so they therefore just push their clients towards it and say like AA, and
Yeah.
they don't know it. I think a lot of therapists still don't know a lot about DBT and about like the fundamentals of DBT and how useful the DBT skills can be when it comes to sobriety. And I also think, like, just in my opinion, a lot of people just don't realize that, like, one approach to anything, whether it's sobriety or a relationship, a
Yeah.
bad relationship, or anything in life, just one single approach and pushing someone into it is probably never going to work.
Yeah.
And so I think not only in DBT, just in any area, giving someone the freedom to choose and letting them make mistakes and realize on their own, and having somebody be able to validate and coach them through that and have empathy for their experience instead of this like jails, institutions, and death approach, and
Yeah.
like, oh my God, you relapsed and it's the end of the world and you have to stand up and humiliate yourself in front of everyone and start all over. And
Yeah. Yeah.
it's I just think a lot of therapists just don't have that knowledge yet. And I also think if you haven't gone through it, as somebody that's been in the 12-step program, I was sober for a very long time and am not sober now, and am fine. It's just something after many years of sobriety, I didn't feel like I needed anymore and didn't.
Yeah.
Um, I think I just think it's like, I don't want to say in ignorance, but I just think it's something a lot of therapists aren't trained in and should be in school, that there is more than one approach to sobriety.
Yeah.
And not everyone does need to be completely 100% sober from everything.
Right. Yeah.
That's really my
Yeah.
approach.
No, you're
I know
preaching to
it's
the
sort of
choir
like,
over
it's
here.
very controversial. Like when you say to someone, well, maybe they don't need to be completely sober from everything, but
Yeah,
I
I mean, that's a
really not
very it's a
your
very
opinion.
American, United States, specifically Western mind that, there is sober and not sober, the binary of black and white. I grew up conservative evangelical Christian, and so I always joke that like the institution of Christianity kept me alive while abusing me the entire time because it was it was an important cornerstone of identity. And as someone who struggles with who I am, what I am, and who I will become, that's, it's constantly kind of ebbing and flowing. I'm aware of it now, whereas before I was like, what's going on? It gave me something to hold on to, and at the same time, the tools it was giving me was basically like handing me arsenic. Essentially, it was like I'm getting substance, but it's poisoning me slowly but surely. And I felt that with the 12 steps. You get that first chip and you're like, I'm on top of the fucking world. You get that second chip and that third chip, you're like, there's nothing that can stop me, I'm unstoppable. And then you lose it, and then you have to argue with yourself. And if you're let's say you're a person who doesn't have a personality disorder, let's say maybe you have a major depressive disorder and you have a substance abuse disorder, and you lose that chip, yeah, you might get very depressed. I would argue to say that the person who doesn't know who the hell they are is going to be more messed up by the fact that they just lost something that they thought was the next identity marker. And what you're talking about, and I love that you slipped in, I'm not sober and I'm okay. Because there's this idea in our heads where it's like, if you're not sober, you're crashing and burning and your life is up in flames. And did either of you read the book Chasing the Scream by Yohani Hari?
I haven't.
Highly recommend. It's about, he does a long history on the war on drugs and how we got here, but he touches on a lot of different communities that actually do the drug rehabilitation program in a way that we in the United States are just now, I mean, we're about to give up on it, which is disappointing, but we were trying for a second there to do the clean needle exchange, the having drugs available. And there are other countries that are doing it way better than us, and he talks and goes and meets with them. And so like he gives the example of people over in the Netherlands who work with people in the government, like high up in the government, who are also using something like heroin, like something like that, where they're getting to it at a place where they're able to function and essentially have a life worth living. And that like idea of life worth living in DBT was a huge like third eye opening for me moment, where you're like, wait, like this, now you've changed the landscape for me. It isn't this is the life worth living, it's what is your life worth living. And that looks so different for everybody, because our understanding and our experience of suffering is different across the board. And then Danielle, on this note, I had a question for you, because you said that you worked with disruptive mood disorder in adolescence earlier.
Yeah, disruptive mood dysregulation disorder.
Okay, whoa, that is,
I know, it's a mouthful.
that's a tongue twister. How does that manifest differently in adolescence? Because I understand that there is a little bit of important hesitancy to diagnose kids before a certain age. As someone who's reread through my diaries and like kind of given more context to my behaviors, it's like I definitely, there was definitely something that was there. What would it be like? What would it look like for you to interact with these adolescents and give them this diagnosis essentially without closing the door on, they could maybe I don't know if this is controversial, but like outgrow it or become regulated later on, or like their environment changes. Like, what was that like for you working with that population?
Yeah. So a few things. Having disruptive mood dysregulation disorder is a risk factor for developing borderline personality disorder and other forms of pathology in adulthood,
Oh,
which is why early intervention is so powerful, because we can decrease risk the
yeah,
earlier we kind of get in there and equip these kids with those skills. But in terms of the presentation, it's not totally dissimilar. So it's also characterized by mood lability and behavioral impulsivity. We also see a lot of irritability in kids and teens, which I attribute to really like being in so much pain and having emotional overwhelm and not knowing how to regulate. And then in the environment, being surrounded by people, whether it's parents, family, teachers, peers, who just don't get your experience.
yeah, yeah. Wow, that is you hit the nail on the head on that one for sure. Because when I go back, and I think it's best, since I'm not an expert, and I say this all the time, since I'm not an expert on BPD, I'm not an expert in mental health. I'm only an expert on my experience, which happens to overlap with those two things.
Yeah.
Is when you look back, the words that were used to describe me as a child were emotional,
Mhm.
sensitive,
Mhm.
creative, artistic. and these are kind of we're thankfully kind of outgrowing the, asshole genius in Hollywood who's like, oh, he's such a jerk, but it's because he's so smart. Like, thankfully, we're moving away from that model a little bit. Thanks to the Me Too movement, we kind of are pushing those ideologies out. I don't know if you guys ever saw when Jennifer Lawrence was like, I can handle, what did she say? I can handle babies. I work with Bryan Singer, like clear pot shot. And so we're in hopefully a better age of dealing with that type of behavior. But when it comes to children, especially, I know that parents, and this is a question for both of you, I know that parents can be overly cautious, understandably, to like over pathologizing their kids in an age where once you choose something, there is, in a lot of school districts, there's a specific path for that. So once you say, hey, my kid has ASD, right, now there's a specific path for that kid in that school. I think of it as something like less intense, like if your kid has dyslexia, right? If you decide your kid has dyslexia, their schooling now looks differently than a kid who does not have dyslexia. When it comes to these mood dysregulations and differentiating the prototypical common behavior of teenagers coming through, which is like explosive hormones, with what we're talking about, which is somebody whose mood is so volatile that it's disrupting their relationships and their daily life. How can we talk to parents about this in a way that doesn't freak them out or think that we're putting their kids in a box, but also giving them the tools to know like what to do? Because I give my parents, thanks to a lot of time and soul searching, a lot of grace, because what would I have done with their skills or lack thereof and me as a child? Like, I just don't think I would. I think I would have made the same mistakes, honestly. So what does that look like for you guys?
Danielle,
Yeah.
I feel like that question is right up your alley.
Yeah, totally. I mean, there's so much there. There's so much I want to say. So one thing is, I always say to parents, no one teaches you how to be a parent, and certainly no one teaches you how to parent a really emotionally sensitive child.
Mm.
And
Call them super sensors is what we
call
call
them super sensors. Yeah.
I love that.
Yeah. And part of the reason why we approach children and teens with this like super sensor conceptualization is because it really is something that it's a dialectic, right? Advantages and disadvantages. And like you said, oftentimes with emotional sensitivity comes creativity, comes a vivid imagination, comes a high level of empathy and compassion. And so we don't want to like put it in a box of these are things that need to change or be fixed. But really, it's like when we have a child with this presentation, the goal for me, at least as a provider, is to equip that child with the skills to withstand stressors more effectively and really build resilience, right? So it's not about changing the emotions, because they can really be a really beautiful thing. I mean, I see myself as an emotionally sensitive person, and I think that's allowed me to do this work effectively. But it's about creating resilience so that they can manage the emotions and the pain that they experience without engaging in behaviors that are destructive.
and creating emotional resilience in the parents, I think, as well.
Absolutely.
Because I think what we find, and that I even find in myself now that I'm a parent, right, is like, even just this morning, right? My 5-year-old was having a morning this morning.
Oh
She was
no.
having a morning about the bowl that her Fruit Loops were in. And like, oh yeah, I mean, and it was a big deal. And she was very emotional about which bowl those Fruit Loops were in. And it was like a 20-minute breakdown, we really had to talk about like things. And and I think it really is about teaching parents that it's not about like, well, if you don't eat the Fruit Loops in that bowl, then you just aren't getting anything, right? Which is the road my husband tends to go down. Like, you're gonna eat those Fruit Loops out of that bowl, or you just aren't gonna eat breakfast. And like DBT therapist mom has to step in and be like, well, what's going on? Like, hold on, like, what are you feeling? Tell me when you're ready to talk about it, right? And just teaching parents how to like, okay, even though you're getting frustrated and you're feeling annoyed, I was DBT therapying both of them, like with my husband, like, I know you're annoyed right now, but like, let's just stop, like use our stop skill and like talking to her and like really teaching parents like your own emotional resilience of like, yes, you can feel really annoyed with your kid and you can stop for a minute and use your own distress tolerance and emotion regulation skills to realize like they're having a moment. And even though it's over like the Fruit Loops in the bowl, like
Yeah.
teaching parents how to validate and also like use their own skills so that these moments don't escalate into like a really bad morning, because that Fruit Loops moment could have turned into like an hour-long like thing, right?
Yeah,
And that's just
totally.
like a small example, because when you're dealing with, you know, with some of the kids Danielle works with, these 13, 14-year-olds, that's not a 5-year-old, right? It really can escalate into something very unmanageable. So I think also when we're working with the parents, because in DBT, the parents work with a separate therapist than the teenagers, it's really about also teaching the parents, like, it's not about the fact that your parenting is wrong or that you're doing the wrong thing. It's also that as a parent, you have so many emotions that come up and so many of your own frustrations and your own stuff that comes up around how your kid is talking to you, or that your teenager is being mean, or your 8-year-old is not doing what you want, that like it's really about putting your own feelings and using your own distress tolerance skills to like maintain that while you're also trying to validate and de-escalate your kid,
Yeah.
you know, so that
Yeah.
things don't. Everything in DBT, I always feel like, is about not making things worse.
I
Like,
mean,
let's just
yeah,
not make it
honestly.
worse, and then we can circle back later
Yeah.
and figure out like how to problem solve.
Yeah. Yeah. No, I agree. I agree. I think what is really crucial is for parents to remember that they just genuinely don't know what is happening inside of a child's brain and body. I think that's hard for us as adults to look back and realize that I genuinely have zero memory of what it was like to be inside my body at that time. And I
Yeah,
don't
I don't know
know.
what was why she was so mad that she wanted a
Yeah,
different bowl for her Fruit Loops, but she really wanted a bigger bowl.
right. Right.
Like, and she
Yeah.
wanted her blue bowl, and then she wanted more Fruit Loops and less
Yes.
milk, and she was really mad about it. So,
Yeah. No, and it's like, what if I mean, like it's a great example because like what if that's just the first time that thought had ever come across her mind? Like, wait a minute, I actually don't fucking like this bowl. I actually hate this bowl.
and
But
she was crying and mad,
yeah,
and like it was like, oh, you know, okay, let's fix it, and then she was fine.
yes. Yes. So, okay, so we're talking about, how to help kids regulate their emotions and also give the parents the skills. What my dream would be is to kind of eliminate this default to the 12-step model and have I thought it would be totally realistic to have DBT groups pop up every night, everywhere. Not necessarily people who have to be trained in DBT, but the same kind of volunteer model of people who have gone through the program, who understand the ins and outs of it, who can lead a group in a way that where they're not replacing a therapist, nor are they doing full blown DBT because they're not doing phone coaching, they're not doing the team meetings. However, they are at least giving these people a new frame of mind and plenty of skills to potentially work from. And at least they're getting their toes in the water to at some point perhaps have access to full on, complete DBT. What do you think we would have to do, even just in California, right? Just let's focus just on California to make that more of a realistic outcome. Like what would we have to do as a DBT community, right? Is it just me calling the government every day like, why is this not legislation? Why is this not legislation? Or is it really just kind of a grassroots thing of hey, I'm going to be hosting a DBT skills group. These are the people who it's for, and then going from there. In your experience,
I think one thing that comes to mind for me, um, and I'm sort of noticing myself wanting to ride this dialectic of empowering the community and that idea of peer support, because I think that can be really transformative. Um, and also being mindful that people who aren't trained clinicians may not be equipped to handle some of the things that might come up.
yeah,
So I think that one thing that would be really important in establishing that sort of support network would be figuring out who's appropriate for that sort of model versus
yeah,
who really needs to be in a therapeutic setting with trained
right,
clinicians. Because I think in that kind of environment, a lot of things could come up, especially
yeah,
when you're taking a group of people who are all seeking or needing DBT and putting them in a room,
yeah,
you know?
Yeah.
I know. I think that's the thing. I was noticing, like, for some reason, like when you were saying that, like this like very nervous feeling came across my
You're
chest
like,
because
oh
like
no.
no, not like an oh no, but like there is this dialectic of like DBT is so needed and so sort of like out of reach for so many people. And I
Yeah.
think one of the reasons is because it is such a specialization, because even when you're teaching the skills, like it's there's so much. It's not just about, with tip, like dunking your head in ice. It's like you have to know where you are on the SUD scale, and you have
Yeah.
to be able to teach the neuroscience of, what's behind the ice dive. It's actually about like, the cold dive reflex and the neuroscience of what's going on in your parasympathetic and your sympathetic nervous system and the brain science behind it. And so a lot of what I think actually has already happened is a lot of like very well-meaning therapists will take like maybe an available weekend training or an online training in DBT. And then they pick up the skills book and they run a skills group for
Mm,
people. And they're not really intensively or even foundationally trained
mm,
through BTech or another place. And they run a skills group and they don't know how to teach the neuroscience or when to use which skill depending on where you are on the SUD scale. And also, I think phone coaching is really an integral part of using the skills, because if you're not offering phone coaching when people are using the skills, often people are using skills that they're using the skills at the wrong time because they don't know which skills to use when,
yeah.
based on where they are on the SUD scale, which is why skills coaching is such an integral part of learning the skills. And so it is this dialectic of skills really needing to be available to people, and what that might attract into a group that's open to the public.
Yeah.
I mean, we just had last night in our adolescent group like a crisis in the middle of skills group where we were like, chasing this kid down, and it was a Zoom group. And so you just, I think you would have to be really careful about like vetting who's
Yeah.
coming into the group and what might happen in the dynamics of the group. And anytime you're leading any kind of a group, like, I just think so there is this sort of, it's out of reach and it shouldn't be.
Yeah.
Um, and I think it's what it should be more about. And I think what a lot of people like Liz Dexter Mazza, who's doing DBT in schools, and Choices out in Sierra Madre, who are offering low fee programs. And, we have pro bono spots available to people. And I think we've talked a lot about being able to like offer, more low fee. I think what it's really about is getting DBT trained clinicians and people who know DBT to be able to offer it to more people for a
Yeah.
more affordable rate, or to be able to offer pro bono spots or more low fee, affordable
Yeah.
care,
Yeah.
than to
Maybe
just
to get,
offer it to the public.
yeah, and maybe to be able to get higher rates of insurance reimbursement.
Yeah.
Forgive my inappropriate but necessary laughter.
Right?
I
Like, I
mean,
mean, I think that's the
I'm
thing
just
is
saying.
like if insurance, this is a whole other political
Right.
topic, right? But if insurance would reimburse therapists the rates that they should be,
Yeah.
then,
Mhm.
DBT clinicians would accept insurance.
Yeah.
It's just that we're on call 24/7. So
100%.
it's really hard to bill insurance. So, but that's a whole other topic.
Oh yeah, no, I will gladly have you both back on and we can talk about the specifics of insurance. That is such a
That is
specific
the
beast.
reason why DBT is not widely available, because DBT therapists are on call 24/7 for their clients, and there's no way to bill insurance for that.
Yes, yes.
So
Which wait, I don't want to lose this thought real quick. What were the names that you just said? You said Liz Dexter.
Liz Dexter Mazza is a wonderful clinician. Their DBT handle is, I believe, DBT in schools.
Mhm.
She was trained under Marcia. She actually trained me at BTech.
Oh,
She was trained under Marcia Linehan at the University of Washington. She was a PhD student, and she did DBT at Marcia's clinic for years. And now she and her husband have formed an organization called DBT in Schools, and their sort of mission is training teachers and counselors all across the country. They're going to schools and teaching teachers DBT skills to teach
Wow.
children in schools everywhere
Wow.
DBT skills. It's absolutely wonderful what they're doing.
That's amazing. And then you said
Yeah,
another
it is
name.
amazing. And then Choices, it's called Choices Skills and Counseling Center. It's in Sierra Madre, right outside Pasadena.
Okay.
They do have a low fee DBT program, where they have trainees that are in school and they're teaching them DBT, and they offer DBT for low fee.
Wow. Wow.
Help.
Cool. It's always good to find other, I'm finding that, like, like when you go to a very small school and all of a sudden you meet like 10 people in your town, like they also went to that school. I'm just
Yeah.
the more I talk to DBT therapists, you guys are telling me awesome things about programs and people I didn't even know existed. So just,
Yeah, and at SoCal DBT, we have, each of us have sliding scale spots. We do have a wait list right now for those, but we do offer, all of us have 2 sliding scale spots on our schedules. So we all have sliding scale clients that we see.
so what I'm hearing us say is that while the intention to make DBT more accessible is the goal, the landing mark of it really needs to be the people who are prepared to expand that goal. Because if we're going to give the amazing tools of DBT to more people to do it effectively and to do it actually the way that Marcia wanted it to be presented, you have to be fully engrossed within the community and fully immersed within kind of the ideology before you can step into certain leadership roles. I'm not hearing you say that it wouldn't work with particular groups, like maybe parents who aren't across the personality disorder spectrum, right? Like that could be a group that would benefit from somebody who isn't necessarily a DBT therapist, but who understands the skills. And I'm hearing you say that even that might be problematic because if the parents are experiencing a crisis and you aren't able to give them the skills specific to that crisis, then you may end up doing more harm than good, despite the intention of it being, more accessibility. Is that kind of what I'm hearing you say?
Yeah, and there is a group for parents across the country called Family Connections that's free. That Alan Frazzetti's at Harvard, right? Alan Frazzetti, who also worked with Marsha Linehan for a very long time and is
Yeah, I love his
a
book. I read it.
DBT god
I
for
love his book. I read his
DBT.
book, High Conflict Couples. That was
Yeah,
that
yes,
was a
and
very
we've
important
all
book.
been trained by him, and he actually was a consultant in our practice for a year. He consulted on cases for us for a year, and he's
Whoa.
absolutely amazing. And he started a program called Family Connections, and it's free. Any families can take it, whether their kids are in DBT or not. It's offered all over the country. And so usually when people are looking for help and they can't afford DBT, or they just have a family member with BPD, anyone can take Family Connections, and it's a wonderful program. So
Wow.
that's a really great
Wow.
resource.
That is super cool. Yeah, because the access part of it is where a lot of the frustration lies. Is one, people don't know about it enough, which is a little frustrating. And then two, once they find out what it is, getting either, in California, it's fairly obvious that the line of we'll give you free programs to the one notch up to where you don't get those free programs anymore is very stark. And it was something as important as, DBT is, I find it a little disturbing that it's not more of a priority because in my opinion, like, it is something that is very malleable and can be used for just a wide variety of populations. Like with the proper training, I see it as a resource for our houseless community. I see it as a resource for low income communities. I see it as a resource for empathy training for people who are like in the 1%ers of California, right? Like I don't see any limitations on who can benefit from the
There
dialectical
isn't.
behavior.
Everyone
Yeah,
can benefit.
there isn't. And so you both touched on this, and it's going to be interesting because I'm bringing on some psychodynamic therapists down the road, and I can't wait to pick their brains. But you both have touched on, and my previous guests have touched on, that you experienced the psychodynamic approach or the behavioral approach. I had one guest who said that she didn't know about DBT until her last semester of her graduate program, and it was like kind of a passing class, like a passing thought class, like very small world. And she experienced that and then like totally changed her whole trajectory and went in full-blown DBT. What is it about the psychodynamic approach that isn't enough for my population, for people across the personality disorder spectrum, or who have such a difficult time regulating their emotions? What is it about it that doesn't take us over the hill, so to speak, to that next phase of growth?
I mean, I think we both have, I mean, I don't, I want to be really careful because I think I have a lot of friends that are psychodynamic psychotherapists that are wonderful therapists. And to be very honest, like psychodynamic theory is my foundation and it's my home. And I lived there for many, many years. I was in psychoanalytic training at PCC when I switched over to DBT, and I trained at the Maple Center for many years. And so it is my foundation, and it's really where I live and where I assess from, and I still use it a lot. And I think it's a wonderful modality and works very well for a lot of things and for other disorders. Be I think it works very well for some people. And I think when you have certain people that need certain levels of validation or really need feedback, going into a room sometimes where someone might just be repeating back what you're saying or might not be speaking at all,
Hmm.
or might just be making interpretations, a lot of times can feel incredibly invalidating to
Yeah.
someone or incredibly anxiety provoking. But I also think even if not, because even when I was doing psychodynamic theory, like I'm just really talkative and things like that. I think that I always now think of it as the why.
Mhm.
And once you get through the why, which could take years, right?
Yeah.
Like it could take years to figure out why you are the way you are, even if that takes 5, 6 years and you get through, you can do a lot of trauma work and a lot of like, figuring out your childhood and why you are the way you are. People really want to know then, like, well, now what?
Yeah.
Especially with BPD or
Yeah.
especially with trauma or especially with behavior stuff. Like, okay, well, now what? Like, how do I change? And in psychodynamic theory, at least the way I was taught, was you don't give direction, and the really what I was always taught was it must be really frustrating that I can't give you those answers. And like, let's talk about how frustrating that is for you.
Yeah.
And I know Danielle probably has her own experience to talk about, but I just never could get into the how. And um that's where I just felt really stuck. And I I guess it's a really good question when you have people on because I would have loved to hear, and maybe I can ask my psychodynamic friends that really are analysts what they do,
Yeah.
because you really are told when they train you that you don't give direction.
Right.
So I think that's where my problem with it lies. But I do think it's a really, for higher functioning people that just want to go in and explore their inner world and explore themselves and just want to talk,
Yeah.
it's a wonderful modality. But when you have somebody who's really in crisis and needs you to say, like, you're not going to do that, here, do this instead,
Yeah.
it just doesn't work. Although they do have mentalization-based therapy, which I know is like supposed to be for BPD. Well, I don't know. What do you think, Danielle?
Yeah. So I, like Suzanne, also still use psychodynamic theory and interventions in my work outside of DBT.
Mhm.
I also use a lot of attachment theory, and I
Mhm.
think insight is really important. And I love
Yeah.
helping clients further understand their inner worlds and how they arrived at the place they're at. And I just really believe that insight is not enough,
Mm.
right?
Yeah.
Because it helps us, again, like Suzanne said, it helps us to understand the why, but then people are still experiencing all of this suffering in the present. And I don't believe that gaining insight is enough to create change.
Yeah. Yeah, I would just want to validate that that's entirely accurate to my experience. Like there was, it's because I'm a very inquisitive person, and like, I like understanding how things work and why things are the way that they are. And when somebody says, for example, you're this, well, then I want to go read 10 books on what this is because I want to understand exactly where this is coming from. So of course, you know, like for example, once I started to understand the type of trauma that I had endured, I went and read a bunch of books on why that was problematic and why my parents probably did the things that they did. And it fostered a lot of anger and resentment towards my parents, which I think is a healthy first step for people who are trying to understand what's going on. Like you should be mad at your parents for a little bit and hate them for a little bit
Everyone
because
needs to be mad at their parents for a little
yeah,
bit.
yeah, yeah. And then essentially you get to a place where I think it's hard for people to get to, where you go, okay, you know, and the dialectics are they had parents as well. So how did they, what did they survive? Like where am I in this chain? Because this isn't like lightning striking. There is like clearly a lineage here. Um, and it was just deeply frustrating to continually get to a place of insight without the how. Like I would be a master of the why. I could tell you exactly why I was doing what I was doing and why I thought what had happened. And then I would be like, well, fucking now what?
Yeah.
Essentially. And I remember, because I was in psychodynamic talk therapy from age 11 to age 18. And then I went to a private Christian school, and they have something called spiritual direction, which is not super effective. And then I was lucky to have an RD who was in my dorm who was getting trained in psychodynamic approach. And at that time, I was a Christian, so it was a good fit. And so then that was another kind of next step for my therapy journey. And then after that, I landed a different therapist who he called himself eclectic. He taught me a lot of things, but I've recently learned that eclectic is kind of a dirty word in the psychological community. Apparently, you don't say that anymore. Apparently, it's something else. It's uh, multifaceted, some other word. Anyway, I'm not in the community, so I wouldn't know. But anyway, and just through that time, all it was doing was creating a deeper sense of self, but remembering, as you both know, I don't know who I am. So the deeper you go into who you are without actually having an understanding, like, or like a self to fall back on, you're essentially just like throwing more ingredients in the blender until like all you have left is like this weird tar shape that's like, I guess that's me. Like, are we drinking this thing now? So yeah, what you said makes perfect sense to me. I wish more people were open to, or at least what I've experienced is I wish more people were open to that next step. Because I like what you're saying. And I think what I'm hearing you say is that the psychodynamic approach does have a place in our world for people who are looking to kind of go to maybe places they've never gone to within themselves.
Hmm.
And there's only so deep you can go without also starting to accept that you need to, if you want to change, these are things that you have to do, which is then how you kind of are talking about like the how of it. And that's what I've enjoyed about DBT is, okay, we're going to do deep work if we can. And I'm also going to tell you exactly what to do when this situation comes up. And if you do this exactly as I say you do it, and it doesn't work, then when we come back together, we're going to talk about what to do in the next situation. We're going to do a chain events. We're going to talk about it together. We're going to go over your goals, you know, yada, 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 whatever it may be. Um, so that makes sense. And I'm hearing you say that it's actually a strength to come into DBT with other approaches in mind, because it's just a deeper bag. Like you're coming into the room with a more holistic understanding of not just the how, but also the why. So what would
And
be,
Marcia has that in her biosocial theory, right?
oh
I feel
yeah.
like that kind of is that.
Yes,
So
well, yeah, when I read her book, it was incredibly validating to
yeah.
just experience somebody who had literally gone through a similar situation. And stories are so powerful. So when you hear somebody else survives, you're like, oh, it's possible. Like this is something I can do. And my parents had a lot of questions after I went into the hospital, understandably. And I eventually gave them her book, and that was like kind of a big connection point where it was like, look, I can try to explain. I feel like if I explain, I might end up triggering some unconscious things that maybe we haven't talked about. Why don't you just read this stranger's story that very much aligns with my experience, and we can talk about like where the story overlaps. And that's been very helpful. So I also want to touch on the fact that you both have such extensive experience with BPD specifically. Um, right? Not just you, Suzanne, Danielle, you as well.
Mhm.
Okay.
Yeah.
Because what I keep running into, and I can't remember if we talked about this on the phone already, Danielle, is I keep running into people in the medical field who are pushing back on my diagnosis. And they push back for two reasons that I've experienced. The first is I'm a male, so that seems odd to them that I'm also borderline. That's been one feedback I've received. And the second one is that, well, no, you're probably bipolar. And the more I read about BPD, the more I came to understand how easy it is for people to get misdiagnosed with bipolar disorder, like 9 times out of 10. I'm me, so I'm not going to just like take that information lying down. Like I had recently have a nurse practitioner who was like, "Oh, you're bipolar." I was like, "I'm not," and I would appreciate if you didn't just throw that out there. And it's interesting because, sorry, I'm going to get to the question eventually. It's interesting. It's interesting because there is still this odd misunderstanding stigma in our world, essentially, especially on social media. So I'm wondering, in your experience with your practice with people with borderline personality disorder, what is it that you're doing to help them kind of become resilient against those outside invalidations, essentially? Because like I have my experience and what I kind of took away from DBT, but I'd love to hear what skills you're giving people with borderline to use that as like a superpower instead of a limiting and a negative judgment, right? Like finding out you have BPD can be really scary because as soon as you start researching it, you learn all of these scary things, and then you go look in Hollywood and you're like, oh my God, if I have BPD, I'm either a serial killer or a kidnapper, like you know. So, what has been your guys' experience with giving people with BPD the tools to withstand that invalidation?
I mean, I'm sure we both have different experiences, but like as far as the invalidation, I mean, usually it's just consultation to the client, which is like helping people do exactly what you did, which is to help them use interpersonal effectiveness skills to advocate for themselves. And
Yeah.
I mean, also, I think we do a really good job of being collaborative with other providers. And I have several clients that have been misdiagnosed with bipolar 2, and they come in and I'm like, you're not bipolar, you have borderline personality disorder. That's not what's going on. Although the same medications often help
Yeah.
bipolar 2 and borderline, so mood stabilizers often do help BPD. But I think as far as like just the diagnosis and people freaking out when they get it, usually I just say it's like so over pathologized and it's really not a big deal. It's just attachment trauma. That's all that it is. It's not, it's just attachment trauma. If you look at the biosocial theory, it's just
Yeah.
attachment trauma.
Yeah.
It's, you know, your needs were not met as a child and like appropriate reactions and feelings were not modeled and validated for you. So you have attachment trauma and that's it. Like, so
Yeah.
forget the name, throw the name out the window, you have attachment trauma and that's it. And so, and it is so over pathologized and so misunderstood by, unfortunately, by doctors and therapists too. So I usually tell them you've landed in the right place. So, you know, don't worry about it.
I love that. Danielle,
Danielle,
similar.
what's your experience?
Yeah. So similarly, providing psychoeducation is really important. And sometimes having to provide some of that psychoeducation to colleagues who don't have the same experience with the
Mm,
diagnosis or the treatment model.
yeah.
Um, so definitely sort of like depathologizing. I also will say to clients all the time, this is attachment trauma. And this is where understanding the why can be so helpful.
Yeah.
The other thing that I really appreciate about DBT, especially compared to some other treatment modalities, is we don't use terms like maladaptive.
Mm,
And in fact, I often will kind of reframe it to clients like these behaviors developed as an attempt to get your needs met,
yeah.
right?
Yeah.
So it's actually kind of an adaptive response and pretty resourceful, right? It's
Mhm.
just
Yeah.
not working for you,
Yeah.
right, in
Yeah.
adulthood, or even before adulthood, if those behaviors are causing bigger problems later on down the line or putting you at risk or destructive, we need to find a different approach. But
Right.
so much of this presentation is an attempt to get a need met.
Yeah.
Yeah. Yeah. 100%. I think I love that you keep reframing it as attachment. Would you said attachment disorder? Is that what you said?
Attachment trauma. Mhm.
Attachment trauma. Yeah. It can be frustrating to learn that there was, needs not met, and it can be incredibly validating to learn that you can meet those needs as an adult. I think that was very powerful to understand that, you know, you are still in many ways playing out these versions of needs not being met because of just essentially a knee-jerk reaction that has kept you alive, while also understanding that as an adult, like for a lot of reasons, like I'll speak for myself, like you're in control, like you are now the person who is making the choices for you, and that can be incredibly powerful, especially if you've been so used to making terrible choices for yourself, not realizing that you were still adapting to situations that weren't around you anymore. Which leads me to my next question, right? I identify male, I'm a masculine guy. What is your experience across kind of gendered lines when it comes to the presentation and the experience of somebody with BPD who has a more feminine ideal or a feminine identity versus someone like myself who has a masculine identity?
You want to answer that, Danielle?
Sure. I
you work
mean,
with men,
certainly this diagnosis is overrepresented in women for, I think, a few different reasons. I think one reason, though, is that more often people who present to therapy are often women, right?
Yeah.
So there's going to be higher rate of diagnosis for people that are seeking services. And I think we need to learn more about how BPD presents across the gender spectrum.
Yeah. Yeah, I agree. I agree. Suzanne,
I
anything to
also
add?
think there's a somewhat sexist thing going on where
Oh yeah. Oh, for
anytime
sure.
a woman presents and there's like any sort of like emotion dysregulation or something happening, like a BPD diagnosis, like, you know, anytime there's some SI or some, you know, there's something going on, like, you know, often a BPD diagnosis can get thrown on them. So I've sometimes had clients get referred to me where they come and I'm like, you don't have BPD, that's not what's going on. But you know, I mean, were you asking like what the difference in presentation is between men and women who have BPD?
Yes, I just
I
realized that
find, I
it's
mean,
a
just to me, like I've found that, I mean, I don't know that there's definite differences because I think everyone is just different as a person. I
yeah.
think I've found sometimes that like men, some men, I've found it tends to be more internalized, like
Mhm.
internalized rage and
Yes.
things like that. It's not as outward as sometimes you see in women. Um, but again, then everyone is different. So sometimes, you know, you see the same symptoms in men. So I think, you know, there's not really a box where you can say like men who are have BPD present this way. And but I do think that more often, I mean, and that's just the socialization, right, of the gender norms of men and women, where I think men who have depression, it's usually rage turned inward, and
Yeah.
women it's outward.
Yeah.
Um, but I think that speaks more to like societal norms.
Yeah.
Um, yeah.
Dang it. I just realized it's freaking 11 o'clock already, which it makes me so sad. I have so
Thank
many
you
more
so much for having us. This was so fun.
I have so many
Yeah,
more
really.
questions for you. You guys are just wells of knowledge and so gracious. I'm so thankful you could come on and just like educate
Anytime.
me and educate everybody else. Yes, I will definitely have you back on. Uh,
Yeah, thank
thank you
Love to.
both so much again. I so appreciate this. Have a lovely
you.
rest of your Friday, and I'll let you know when this posts so you can
Yeah,
check out.
definitely.
Yeah,
Love
so
to.
awesome.
Thank you
Thanks so
so
much, you guys.
much.
Thank you so
Bye
Have a
much.
good morning.
bye.
Bye.
Bye.